It's something that a lot of you do, and it can scare people, and it can definitely change the way patients react to certain things. It also confuses the crap out of patients sometimes too. And when patients get confused, they get flustered and like do weird stuff. I've had patients, get so flustered they can't even function. I don't know, just because I over-explain something and they have no idea what I'm talking about. But they think they should, and then they get embarrassed if they don't. I don't know if any of you have experienced that. I've experienced that a lot with over-explaining things. So with something like cervical compression, I'm just saying, I'm going to push on your neck. Tell me if you feel anything. Done. It's really easy to understand as a patient. Tell me if you feel anything. I actually got to stop saying feel. I want to say if you notice any symptoms, because I've had people be like, well, I'm starting to feel sad. Like, I honestly don't, I mean, it might be important, but I have no idea what to do with that. That makes my head want to explode. And that happened multiple times. So I'm trying to retrain my verbiage. Not just the sad stuff. They start getting into feelings, because that's literally what I asked them to do. So I have to be careful with that. And that's why I'm really cognizant about the things I say to patients, because I do have those experiences. And then it screws things up. Then all of a sudden we're going down that road of talking about that, and that makes me uncomfortable. That's one of the reasons I'm a chiropractor. So I'm just going to push down on your head. Tell me if you feel anything. I said it again. I'm starting to feel sad. All right, repress that feeling. Or continue to repress that feeling. So that's the first step. Now, if, let's say, you came in with neck pain and maybe some radiating symptoms down the right arm that I was trying to investigate, see if it was a radiculopathy. Let's say I did that and you were like, oh yeah, that makes my index finger go numb. I probably wouldn't go and do the next two tests just because they stress the nerve roots even more. But for sake of flow, we can do Sperling's as next. And I'm going to have you just bring your right ear to your right shoulder. And the other way around, the ear to shoulder, not shoulder to ear. There we go. So just like that. And if that caused symptoms, then we'd be done. If it didn't, then I'd compress. With this one, to do this one is the best way possible. You kind of want to compress like this. That makes sense? Like along the spine. What you don't want to do is just crank the neck into lateral flexion even more. Because that you're going to get a lot of false positives there. Because that, I mean, you're pushing the neck past its physiological line range. So I usually line my forearms up with the neck and then just kind of compress this way. Notice that I'm not moving the head back to neutral when I do that. I'm just kind of directing my force in kind of a curvilinear direction. So that's probably a better way of doing this test. A lot of people end up just cranking the neck out, and then you get a lot of false positives. So then the last one is maximal foraminal compression. Bring it like that. And kind of same thing here. You want to compress along the spine and not just crank your neck out that way. And if there were negatives with all of those, that's good. We move on to the next test. And now we got to start stretching things. So I do shoulder depression first. Maybe not first. It just flows better if the patient's already in the seated position. And then I can do upper limb tension test. Going like that. All right, you're holding there. So the thing with upper limb tension test, one of the things that almost everybody gets wrong if they don't do this test on a regular basis is you got to start out with kind of, it's almost like palm to fingers and then with this thumb. Because eventually I'm going to have to extend this wrist and hand and fingers, and if I'm holding here, that happens. And then you're just not even doing the test right. So like this to start out with, or like this. Then I depress the shoulder, abduct the shoulder, externally rotate the shoulder, extend the wrist, hand, fingers. Okay, and go ahead and bring your left ear to your left shoulder. Does that increase them?
No.
Okay, bring your right ear to your right shoulder. Does that decrease them?
Yes.
Okay. So, why did I do the head thing when she felt symptoms?
To make sure.
To see compression.
No, to make sure it's the nerve. That's it. It's called structural differentiation. If where were you feeling your symptoms?
Like when you started.
No, where in your body?
I
Yeah. So that could be because I'm stretching some of the muscles here. But if it changes at all, whether it gets worse when you lateral flex away or better when you lateral flex towards, then we've just confirmed that it's coming from the nervous system, because that's the only thing that's being stretched when you move the neck. That can actually be felt here. So we've differentiated it from anything local. That's the other thing that people do wrong. They just misunderstand that. Or they have the patient rotate their head. That doesn't do it. You have to have them lateral flex away and towards, and they have to actually lateral flex. So it's kind of bend your head to one side or bring one ear to one shoulder, not look to one side.
Is there a reason you can't do it seated?
Yes. Because it's not done seated. That's the way the test is done. And seated will definitely change your relationship with gravity and make it a lot harder. You probably need like 4 hands. So that stretches the median nerve and tugs on the brachial plexus, which tugs on the nerve roots, contributing to the brachial plexus, specifically more like C5, C6 nerve roots. And it's part of a cluster of diagnoses for the cervical spine. The cluster is positive compression, positive distraction, which is where we're going to go next, positive upper limb tension test, and then the inability to rotate your head past 60 degrees. So normal rotation somewhere between 70 and 90 degrees of rotation. Inability to rotate it past 60 degrees means something's going on with the neck probably. So let's go ahead and sit up again. So that's just active range of motion. Now we do distraction. Try to grab onto the head, try not to squish ears too much. You're going to be on the ears, it's fine. Not stabbing patients with their own earrings or anything like that, but I want to get a nice hold on the head. Distract. Hold it for a couple seconds, and then slowly let release. And what you should notice there is, especially if the patient has any radicular symptoms, that when you do that, they actually get better, and that's a classic positive for distraction. Anything else, you just have to interpret accordingly. You know, a lot of people are like, that just feels good. Well, that's not really a positive, but it's good that it feels good, because that means that the muscles and ligaments and tendons that we're stretching when we're doing that are probably not damaged, or at least damaged to the point where the nervous system thinks that motion is threatening. But the classic positive is if a patient has kind of neck and arm symptoms, you do that, those symptoms get better, or the arm symptoms recede or go away. And then motor reflex and sensory. One thing I need to say with motor reflex and sensory is if you do one of those tests, whether you're doing like a reflex or testing a muscle for motor function or checking a dermatome, you do them all. It's a group of tests. You do them all. And I'm starting to get aggravated with the number of times I'm seeing patients with potentially neurological issues just have like one reflex tested and then referred over to me. Probably because they have no idea what's going on. Yeah.
Can you do it in like compartments of the body? Like if it's upper limb, can you just do
Yeah. I mean, if you're thinking neck and arms, then not necessarily. But if you get some positives, if we do the arms and start getting positive, then you should check the lower extremity, because it could be a spinal cord issue, and that might show up as upper and lower or bilateral. So it's really important if you do. If you got neck and arm symptoms and I decide to do like biceps reflex, you do motor reflex and sensory, the entire set of tests. You do them from start to finish. Yeah.
For sensory in the upper limbs, are you doing sharp roll there also? Because I've only ever done sharp roll on like the lower legs. Or how are you checking sensory in the
Sharp and dull.
Sharp and dull,
Yeah. Unless you're just screening. And if you're just screening, you've already kind of ruled out a radiculopathy and you're just making sure.
And so how would you screen?
Light touch.
Light touch like with a cotton ball, or light touch like where you're just using?
It could be with an action figure, I don't care. Just light touch. Some people, I've had instructors here say, I heard you're teaching light touch with fingertips. Like, I think I don't think we should be touching our patients. And I was like, please stop talking to me. Like, yeah, we can do them with cotton balls or cotton swabs or fingertips. If I'm screening somebody, let's say you come in with neck and maybe a little bit of radiating symptoms, but from the history and I ask some good questions, I'm pretty sure it's not radicular. Well, then I'm just going to screen. And just screening, I would, with, on skin, be checking the different dermatomes just with my fingertips. And I wouldn't necessarily break out the cotton ball or cotton swab or anything like that, but you can do that if you want to, it's totally fine.
And just having the patient close their eyes and tell you if it feels the same?
Yeah.
Or- okay.
Yeah. But remember that if you're gonna do motor reflex, because what's the part of the motor reflex and sensory testing that we're really paying attention to, which kind of tells us like, we can deal with this, or they need to go see somebody else. Motor. If they have motor dysfunction, then they need to probably go see a neurologist, or at the very least an orthopedist that does a lot of neurology or deals with this kind of stuff. And we had a patient a few weeks ago that had motor dysfunction, but it wasn't tested, and they were sent to us from another shift or community clinic, and there was like a 3-week span in between that first visit and coming to see us, and that's not good, because that could be progressive motor loss, and that's malpractice, and it could be permanent for the patient.
Do you have the symptoms that person had?
It seemed like a radiculopathy, but they just didn't check the motor testing.
Okay.
And they were sent over to us to confirm that it was radiculopathy, and we did, and there was motor dysfunction, and that's not good. We had a patient the other day who didn't have motor dysfunction, but I'll talk more about it. But yeah, that was scary when that happened. It was like I thought that patient was faking. They weren't able to really move their lower extremity in particular ways. And then when we tested it, they could barely resist gravity, let alone mine. So it was like a 1 to 2 out of 5. And they needed to go see somebody right away. And I think they were sent over from the community clinic because the patient didn't have any money to see anybody. This is a fairly emergent situation. So always do the entire package of stuff. All right, let's practice those orthopedic tests.